All right. Okay. Welcome everyone to this, our first renal forum after a break of close to 1 year. So a few house rules. We'll take questions at the end. Please keep your mics muted, and we only have 40 minutes. So if we go off, please use the same credentials to rejoin the meeting. So today's forum discusses the issue of the use of vasoactive drugs in critically ill children. And one might wonder, why are we as a renal forum interested in this topic? And the reason is because 1/3 of our consults are of children with acute kidney injury, and 50% of those children have acute kidney injury because of either septic shock or cardiogenic shock. And many of these patients with acute kidney injury have impending circulatory failure. So as you know, most guidelines tackle the initial identification of circulatory insufficiency and the initial use of fluid management, vasopressor and inotropic therapy. But they are silent on the subsequent assessment, titration, pitfalls, and monitoring of patients for the non-PQ expert, like the people on the renal forum. So today, it is my great pleasure and honor to introduce my friend and colleague, Dr. Kaiser Fitzwanga, who is a pediatric intensivist, to share a few of the secrets of the trade in terms of the use of vasoactive drugs. Now, Dr. Fitzwanga is a Kenyan pediatric critical care specialist with a passion for critical care medicine and aeromedical transport. She has previously worked part-time as a consultant at MP Shah Hospital PICU, was involved in aeromedical transport of critically ill patients with AMRA Flying Doctors Nairobi, Kenya, and is very involved with Critical Care Society of Kenya as an instructor in the basic assessment in intensive care course. She's currently a case management officer with WHO Regional Office for Africa, Congo Brazzaville, where she's been supporting member states, providing technical advice and building critical care skills capacity in COVID management, as well as clinical guidelines review and adaptation. She's currently deployed to WHO country office in Zambia as part of the surge team to provide technical support in COVID case management. Welcome, Kaiser. Over to you.
Thank you very much, Dr. Chisambo. It's a great pleasure and an honor to be addressing the Pediatric Forum in Zambia, and I'm greatly honored. And I'm here to share this topic that I'm very passionate about in critical care, on the use of vasoactive drugs in critically ill children. As Dr. Chisambo mentioned, pediatric intensive care specialist, but I have a special interest in cardiac critical. Just want to, can you allow me to share my screen, please?
Yes.
Thank you. I'm unable to share my screen.
Okay, I'm working on it, Kaiser.
So this topic is a very broad.
I've enabled the sharing.
All right. Okay. Just confirm if you can see the screen.
Yes, I can see the screen.
Okay, I'll just put it on slide mode. So this has been is a very broad area, and I've tried to really focus on very key areas that are pertinent that we commonly face as pediatricians in basically for utilization of vasoactive drugs in critically ill children. And one of the things that we, in terms of our hemodynamic consequences of sepsis, septic shock one of the organs that is greatly affected is the kidneys, because we know that it takes up to 25% of the cardiac output. So this is a very important topic that I'm presenting in the renal forum. And I'll go through a quick review, quickly through a case scenario, overview of the vasoactive drugs, and then touch on the vascular dysfunction on sepsis, because this is the commonest area, and then provide some evidence from the surviving sepsis guidelines and touch on hemodynamic monitoring and some topical issues on the use of serum lactate. So this is a scenario of an 8-year-old who's admitted to the PICU with community-acquired pneumonia, and the patient remains hypotensive with high blood lactate despite volume resuscitation with 60 mL per kg fluids in the emergency room. Maybe we'll give this scenario about 5 minutes to discuss, and then we move on. So how would we manage this child? I would like it to be interactive as possible. So maybe Chisambo, you can look for me for hands raised, because I won't be able to see.
Okay, Dr. Chimwemwe Zulu, at the moment, you are the first to join. So please, what would you do for this patient?
Okay, Dr. Chimwemwe.
Sorry, Dr. Mara, just give me a minute. I just joined it. I'm just reading the scenario.
Okay, so it's an 8-year-old admitted to the PICU with a community-acquired pneumonia and remains hypotensive with high blood lactate despite volume resuscitation with 60 mL per kg fluids in the emergency room. What are your thoughts? I'm sure this is a very common scenario that we encounter as pediatricians.
My thoughts would be that this baby possibly is in septic shock.
As evidenced by?
So this is a baby who has a pneumonia, first of all. So there's a focus of infection and has a high blood lactate, and then came hypotensive, but despite adequate volume resuscitation, still remains hypotensive.
Okay, you're absolutely right. So how would you manage this child?
So I would start this child on an inotrope.
Okay, justify why and what you would be using.
Okay, so I would an adrenaline infusion. That's the appropriate inotrope to use.
Anything else? Anyone else? And Dr. Chisambo, anyone else?
At the moment,
the baby
at the moment, we just have Dr. Zulu.
All right. Okay. 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 So when you're faced with such a patient, remember, to be the structured approach of your ABC. So this is a child that you've done 60 mL per kg. So in terms of your management, you want to make sure that your airway is patent, you're oxygenating well, and because we know that a lot of patients after fluid boluses, they start to have difficulty in breathing, they're quite sick and everything. So these are patients you might want to supplement oxygen supplementation. If you have sort of increased work of breathing, this is a kind of patient that you may consider putting on non-invasive ventilation so that your airway and breathing is sorted. Or if they are profoundly increased work of breathing, it's a patient you may consider, intubating to secure the airway. Depends on the mental state of the patient. And then, of course, you're right to say that in the circulation, you want to you want to start this patient on a vasoactive agent because you have done adequate volume resuscitation with 60 mL per kg. And we know from the pediatric advanced life support guidelines, they recommend doing 10 to 20 mL per kg aliquots or fluids. And usually by the time you're getting to the third fluid bolus, if there's no evidence of improved perfusion and cardiac output, this is a patient then that you want to now introduce a vasoactive medication. So the question is it an inotrope or a vasopressor? So this basically, I brought this case scenario to set the stage for this discussion because this is one of the commonest conditions that we are faced with in pediatrics. And of course, don't forget, you know, in your steps of your ABCD. And I really like the ABCD algorithm because it's very structured and very simple, and you tend to cover all the systems. Not forgetting, as you get vascular access, you're taking off bloods, you're considering having these patients in antibiotics going in within the first hour. You've taken off your bloods for investigation, your cultures, your blood gases, you know, because you want to see where you're starting so that you have a reference point. You're doing your blood sugars, you know, exposure, you're looking at the temperature, controlling the temperature, giving medication if you're pyrexia. So this is basically to set the stage. So just as an overview, vasoactive medication, oh, my slides are not moving, oh, sorry. So vasoactive drugs basically describes, it's a broad term, it describes a group of chemicals which will exert one or more effects on the cardiovascular system. And this is through activation of specific receptors. So there are different types of vasoactive drugs, and they're divided into your inotropes that we commonly know, which will exert effect on your myocardium, and can either be positive or negative. So positive inotropes will enhance your contractility, thereby increasing your cardiac output, while the negative inotropes will do the exact opposite. Then you have your chronotropes, which increase your heart rate. You have your vasodilators and vasoconstrictors, which both work on the smooth muscle walls of your blood vessels. So your vasodilators will cause vasodilation. Your vasoconstrictors, also known as vasopressors, will act directly, causing vasoconstriction. And a lot of these medications that we use, basically, you'll find that they have features of all these properties that we are talking about. They could be both inotropes and vasopressors. So when you're talking about adrenaline, you're talking about a vasoactive drug that has both inotropic properties, chronotropic properties, and vasopressor activity. Okay. This is a very common table, I think, that we remember from basics of right from medical school into our postgraduate. The common vasoactive drugs that we use in critically ill children and the different features. We know that adrenaline has a very strong inotropic, chronotropic activity and vasoconstriction. And the vasoconstriction is really, so this depends on, you know, your doses, because we know the receptors act on both alpha and beta receptors. So when you have high doses above 0.3 mics per kg per minute, then you have alpha activity, which will cause vasoconstriction. If you have low doses, it will cause vasodilation. Noradrenaline has very low inotropic effect. It doesn't have any chronotropic effect, but it has vasoconstrictive effect because it's purely, it has a main action on the alpha receptors. Dopamine has all features of inotropic, chronotropic, and vasoconstrictive effect. And, you know, we say zero vasodilatation. There is some evidence of low doses causing vasodilatation on the renal bed, okay, but not on your peripheral blood vessels. While dobutamine has effects on your, it has high inotropic activity, chronotropic activity, and vasodilatory activity. I just brought this here so that we set the stage. And these are your different, these are the commonest vasoactive drugs that we use. It's important to know their effects, what receptors they interact with, because when we now understand the pathophysiology of the patient that's in front of us, then it guides us in terms of the choices, because a lot of people are, get confused. Okay, is it adrenaline? Do I start with dopamine? Is it milrinone? Others, you find them saying, okay, let's start with the butamine. But just understanding one, the physiology gone wrong, then the effects, the pharmacology of these drugs. And it's also important to be aware of the side effects of these drugs, such that now when you're on high doses and you see certain side effects, you don't get surprised, and it also keeps you aware. Okay, I've added, aside from your common vasopressors, then you have your inotropes like milrinone, which is purely inotropic and has lusotropic effects. Then you have other medication that we tend to use, but not very common, like in the pediatric emergency room. But if you have in the intensive care, labetalol for hypertensive emergencies. I'm sure for Dr. Chisambo, she uses this in renal, those patients who come with renal artery stenosis. We also use nitroprusside in these patients. This is also a vasoactive medication. Esmolol, we use it a lot in the cardiac ICU in those tetralogy of Fallot patients. So just, I decided to just narrow my talk on sepsis, because this is usually the commonest problem that you see in pediatrics. But feel free to, ask questions outside sepsis in the use of vasoactive medication. We know that the cardinal mechanism of vascular dysfunction in sepsis is vascular smooth muscle relaxation. But we know that as part of your compensatory mechanism in sepsis, there's secretion of hormones, different hormones, which will try to increase your vasomotor tone, your heart rate and contractility, and they act synergistically. However, when you have ongoing sepsis, you will find that these regulatory multi-hormone mechanisms get overwhelmed, and you have these patients having persistent hypotension and shock, and it will also, you have also a downregulation of your adrenergic receptors, so hence persistent vasodilatation, and your blood pressure that is unresponsive to fluids. Then you also have increased nitric oxide production, which is induced by endotoxin and cytokines that causes induction of inducible nitric oxide synthase. There's also release of prostacyclin by the endothelial cells, and this will also result in vasodilatation. And there's also an increase of adrenomedulin, which is a vasodilating and cardiac depressant hormone. So it's a whole mix of your vasodilation because of your endotoxin and cytokines that produces these substances, these hormones that will cause vasodilation. You have downregulation of your receptors, dampening your vasomotor tone, and also another effect is also reduced ventricular contractility. So knowing all these pathophysiological mechanisms then now guides us as pediatricians as to what is the next step. You've started your fluid bolus. You do not see any evidence of improvement of your cardiac output. Remember, the ultimate goal of increased cardiac output is your increased perfusion in your microcirculation. That's the ultimate goal. Increased perfusion in your microcirculation leads to increased oxygen delivery. So what's the evidence from the surviving sepsis guidelines? We talk about, I've just picked out recommendations. It's a very big document. I'll put the references at the end. But usually when you're faced with such a patient, you want to start your fluid therapy. That's the first thing to do. And the recommendation is use of balanced crystalloids, 40 to 60 mils per kg fluid bolus within the first hour, and in aliquots of 10 to 20 mils per kg. Usually by the time you're getting to 40 mils per kg and you don't see any improvement in your clinical markers of cardiac output, which would be your heart rate, your blood pressure, your cup refill time, level of consciousness, and urine output, then at that point, we're getting in trouble, and now we're talking of the concept of fluid refractory shock. So that's when you now introduce your vasoactive infusion. The beauty now, and studies have shown that these infusions can actually be given peripherally as you're waiting to get a central line. They can even be given through an intraosseous line. So thankfully, God, are those days where before the advent of PICU specialists, where you'd have to wait for an anesthesiologist. I love my anesthesia colleagues. We work with them, but you know, when they're overwhelmed, they have theaters to manage. By the time you're waiting for someone to come and put a central line for you, time is gone. So the current guidelines, even from pediatric advanced life support, is if you're unable to secure peripheral line within the first 90 seconds of seeing this severely ill patient, you put in an intraosseous line, and you can start either your epinephrine or norepinephrine. And then we have advanced hemodynamic monitoring, which can be used at the bedside if it's available. And these are things that are used mainly in the intensive care unit. But your simple, basic clinical markers like your heart rate, blood pressure, cup refill, level of conscious urine output can be done right from the pediatric emergency. It can be done in the acute room in the general ward. When we're talking about advanced cardiac monitoring, we're looking at cardiac output or cardiac index, which is more objective, because remember, patients have different body habitus. So the cardiac output, just measuring an absolute cardiac output is not as objective because of the habitus. So you want to relate the cardiac output to their body surface area, so that then you're interpreting it in context. Then things like systemic vascular resistance, central venous oxygen saturations, or lactate levels. Lactate, you do it from your point of care blood gas analysis. I just threw this in: the use of hydrocortisone if fluid resuscitation and vasopressor therapy do not restore hemodynamic stability. Remember, one of the pathophysiological mechanisms in sepsis and septic shock with the cytokines and endotoxins, you have downregulation of adrenal receptors. So your use of corticosteroids helps in upregulating these receptors, so that you have increased effect when you're using your vasoactive medication. So I just put this algorithm for the management back before the revision of the surviving sepsis guidelines. In 2000, and these surviving sepsis guidelines are extrapolated from the adult guidelines. We had the guidelines in 2006, and they've been, they used to be revised, 2004, revised every year, every 2 years. And they were talked about early goal-directed therapy, and they had all these targets, for adult septic shock. But over time, they've been studied and shown to really, some of them having those absolute targets, some of them have been shown to not have an impact on your survival. So we're saying that you have a patient with unstable hemodynamics and cardiovascular dysfunction. You have your tachycardia, hypotension, impaired circulation. So the first step is you're giving your fluid bolus, and you want to check, is this patient fluid responsive or not? That's that now along the way, when they revise the surviving sepsis guidelines, instead of saying we're targeting mean arterial pressure of this, we're targeting absolute figures. We want to be more objective. If they're fluid responsive, then you continue with your balanced crystalloid. If they are not fluid responsive, then you want to target their mean arterial pressure, which basically is a marker of your microcirculation and organ perfusion. This is the formula that we use in children, that when we want to look at their as a target, 55 plus H times 1.5 as a target of your mean arterial pressure. And for non-fluid responsive patients, that's when you introduce your vasoactive medication, which is either epinephrine or norepinephrine. And or you want to measure your systemic vascular resistance index. This is quite advanced for those who are in PICU, that you're able to do it advanced. We can do it non-invasively using ultrasonic cardiac monitoring, and this is the target value. It's what we normally would do it and then use a reference chart based on age to determine where the patient is. This is an index that really looks at your peripheral vascular resistance, and what the pathophysiology in septic shock is your vasoplasia due to the mechanisms that I explained. So if you have a patient with a normal, so you want to maintain it within a normal range, and if that is not the case, then, and it's within normal range, but you're still having evidence of reduced cardiac output, then you want to go further and look at other hemodynamic markers, such as your cardiac index. You're looking at other markers, such as your central venous oxygenation, that's abbreviated as your SpO2, and lactate clearance, such that if it is below these ranges here, and the cardiac index can be done ultrasonically in the intensive care unit. The central venous oxygenation is a figure that is obtained from central blood gas analysis. And we're looking at measuring serial lactate levels, and the target is having a lactate clearance that's above 10%. So if you have lactate clearance below 10%, then it tells you that your perfusion in your microcirculation is impaired, hence your increased anaerobic respiration generating lactate. So these are patients that you purely want to add, this is a patient that you want to add inotropic agents, because now you're thinking, okay, you have impaired cardiac contractility. And then basically, the aim of all this is achieving your goals of improving your cardiac output, improving your microcirculation, and in turn, your oxygen delivery. So very important to understand the hemodynamic monitoring when you start patients on vasoactive medication. And we talked about basics, so we're looking at heart rate and blood pressure, very simple. And the goal of resuscitation is having optimal heart rate and blood pressure for patient age. Mean arterial pressure, which if you're using a blood pressure machine, it will give you, and this is the formula that you use. We want to ensure adequate renal and distal perfusion. And in turn, the end goal is increasing your tissue oxygenation. There is measuring your central venous blood oxygenation, which is abbreviated as SpO2, which basically it represents a balance between your oxygen delivery and consumption. And for adult sepsis, they had given a target of over 70%. Studies have shown that, using it in pediatrics, not very reliable. So we use all these parameters together, not one as a single, and looking also at lactate, which is a quantifiable marker associated with tissue perfusion, and you want lactate levels below 2 millimoles per liter. The advanced hemodynamic monitoring I talked about, you have your cardiac output on your cardiac index, and this is the range that's recommended by the Surviving Sepsis Guidelines to optimize your cardiac index within 3.5 to 5.5. You have your SVRI, that is your systemic vascular resistance index, which basically is a marker of your cardiac afterload. And it's an important, as I said, pathophysiologically, a clinical manifestation of sepsis. Normally, we can measure that non-invasively using the ultrasonic cardiac monitoring. There's another concept of fluid responsiveness. So in the adult sepsis guidelines, you're evaluating volume status, which is very important because you don't want to continuously pumping a patient with fluid and landing into problems of pulmonary edema, because another of the other pathophysiologies, you have leaky capillaries, you have that of your glycocalyx, leaky capillaries, and then these are the patients you now start to see have increased work of breathing and pulmonary edema. So the aim of fluid responsiveness is monitoring an increase in your cardiac output post a fluid bolus. And there are certain parameters that are measured. This is the pulse pressure variation, the systolic pressure variation, the stroke volume variation. And this has to be done, it's a bit advanced, it has to be done when the patient has an arterial line in situ. Patient should be, the conditions a patient should be ventilated, mechanically ventilated, and well sedated. Looks basically at, it's basically, these are parameters that are based on the physiology of your interaction between your heart and lungs, what you call the so-called cardiopulmonary interaction, and the effect of positive pressure on your venous return and your hemodynamics. It's been shown to be a bit unreliable in pediatric sepsis because we know in the younger children, they have very compliant chest walls, even their blood vessel, their smooth muscle in the blood vessels is not that well developed. So they are very compliant for blood vessels. So it's a concept that is not very widely used in children. So I thought I would touch a bit on the use of serum lactate for management of sepsis and septic shock. And this is a study that looked at what you call the lactate kinetics. We know that lactate is a byproduct of anaerobic respiration, byproduct of your pyruvate. So a lot of people, would be like, so why do we use lactate? Studies have shown that using absolute numbers is not very reliable for management and monitoring patients of septic shock. You want to do serial measurements, and it has been shown that actually measuring what you call lactate clearance has been shown to actually be a better and more objective marker than actual absolute figures, because there's always an assumption that increased lactate equals to anaerobic respiration, but that may not necessarily be true. But when you're looking at clearance, remember lactate is cleared in your liver. So when you're looking at, the lactate clearance, it gives a more objective marker. And these authors compared doing serial lactate levels from admission at 6 hours, 12 hours, and 24 hours. And it was found that the lactate clearance at 24 hours was a predictor of patient survival, with clearance more than 10% being associated with better survival. Yeah, I'm happy to take questions. Thank you.
Thank you so much, Dr. Fitzwanga, for this very insightful talk. Guys, are there any questions? From our day-to-day experiences managing patients in septic shock who are not responding to the initial adrenaline, you keep going up. This is our chance to get some tips. There's a hand from Buseko. Please go ahead.
Okay. Sorry, that was just a mistake.
Okay, that was a mistake. Okay, Dr. Fitzwanga, do you want to talk to us about mixing and matching vasopressors and the conditions that would have to be present for us to do that? So let's say we start a patient who's in septic shock, as you said, on adrenaline, we're going up and there's no response. You talked about assessment of cardiac function. So there's that possibility of using, adding on an inotrope to support myocardial function. But I've seen people sometimes mixing norepinephrine and epinephrine. So under what conditions is that done, for example?
Okay, so traditionally we would start the patient on epinephrine. If I go back, and that's why I brought out the table on the effects and the side effects of the vasoactive medication. some of the medication, when you go to very high doses, like your norepinephrine causes your splanchnic vasoconstriction. So sometimes you don't want to be just starting with one and going to very high doses when you can introduce an additional, like say if you started with, but for pediatrics, we normally like to start with epinephrine. The beauty about epinephrine, remember it has both alpha and beta activities. In low doses, it has more beta activity. So you're talking about your inotropic and chronotropic effects. Remember for children, because of their, their cardiac physiology, their cardiac output is more heart rate dependent. So when you're looking at improving cardiac output in these patients, you want something that will have effects on your beta receptors. So increasing your heart rate, increasing your contractility. And then should you now want to go higher on the doses, then you can introduce a norepinephrine, which has predominantly alpha effect. So you're working on your smooth muscles of your blood vessels, causing your vasoconstriction, because that is really the pathophysiology in septic shock. So really it's about understanding, what is the pathophysiology of this septic shock that we're dealing with. Norepinephrine is very expensive, and not all facilities have the luxury of affording it. You can also use dopamine as a substitute in high doses. So you have your epinephrine and dopamine, because the high doses of dopamine then have the alpha effects, but it also has some beta effects, and it also has it is a dopaminergic agonist. When you're looking now at patients who, so sometimes you have these patients who have, despite having those high doses of your vasopressors, then you may want to add a bit of inotropy and a lot of these children that come, there's some who have very mixed, it's not a purely septic shock patient. Some may have history of cardiac disease. So those are patients that you might want to also introduce an inotrope, a pure inotrope. Like if you have the luxury of having milrinone, it's also an expensive inotrope, but dobutamine is one that we tend to use as as a substitute for milrinone if we don't have. So it's the mixing and matching. There is no, I can't say the guidelines from the Surviving Sepsis recommend your adrenaline, noradrenaline. But when it comes to, remember, these are guidelines that guide your clinical practice, but your management is really based on the patient that is before you. And one of the things that I want to overemphasize is the issue of monitoring. It's not about just starting your agent and then you wait and watch, because now if you have the ability to do even advanced monitoring, then it will now tell you, because if you're able to do your cardiac output monitoring non-invasively and using your ultrasonic cardiac monitor, which basically measures velocity across the aorta, which varies with your respiration, and then we're able to tabulate the different aspects like cardiac output, systemic vascular resistance. And if you find that your cardiac output is low, but your systemic vascular resistance is within the normal, then it tells you that you actually need to add an inotropic agent. But at the end of the day, it's a clinical judgment, and your history, examination findings, those basics will guide you, and then regular monitoring.
Thank you so much. Guys, is there any other question? Okay, I have a question. So particularly in the neonatal age group, Dr. Fitzwanga, we tend to see quite a few of these kids coming in septic shock with already established, or nearly established gangrene. And then, of course, we know that the agent that Surviving Sepsis has recommended, which is the adrenaline, is causing vasoconstriction. Any thoughts around use of vasoactive agents in the presence of gangrene?
Okay, the pathophysiology, so among the other pathophysiology in your sepsis and septic shock is triggering of your coagulation cascade. So these are patients who, you have microthrombi in your peripheral microcirculation, and that is what is likely to cause, especially in the neonatal age. Unfortunately, these vasoactive agents have not been widely studied. Dopamine is the first line in the neonatal age group, and adrenaline. Noradrenaline, we don't have data for the neonatal age group for the use of noradrenaline. So we tend to just, start with dopamine and then add on epinephrine for these patients. Unfortunately, if the gangrene has set in, at that point, you're looking at what is your benefits versus the risk. Because at the end of the day, you want to increase your microcirculation perfusion. You want to increase your oxygen delivery into your microcirculation. Unfortunately, if you have a limb that has become gangrenous, then there's really nothing much you can do. But, you want to optimize their hemodynamics, because not optimizing their hemodynamics then has your deleterious effects on your kidneys, your liver, your GIT. So sometimes it's a game of, I don't know whether the game is a right word, but it's sometimes you have to sacrifice.
Okay. Have you guys got any other questions? Okay, I have another question on lactate. So I hear you, you're saying that we can't just use one marker as a hemodynamic monitor. So among the many hemodynamic monitoring tools that you talked about was the lactate, and we can use point of care blood gas to do serial lactate. So we know that one of the side effects of using adrenaline is that the lactate may go up. So how do we, interpret the levels of lactate versus the increase in lactate that one would expect from using a vasopressor like adrenaline?
Absolutely, that's a very pertinent question, and that's why I brought in that study that was looking at the lactate kinetics, because it's always assumed that high lactate equals to anaerobic respiration, but high lactate can also be due to increased aerobic glycolysis. And you know that use of adrenaline does cause, it does increase your glycolysis. So that's where the concept of lactate clearance. So you're doing your serial lactate level. So lactate clearance basically is, say you started your subsequent lactate level minus the baseline over the baseline times 100. That gives your lactate clearance, because we know that lactate is actually metabolized in the liver. So that is a more objective way of actually interpreting your lactate levels, and it's doable. So if it's more than 10%, then we know we are winning in terms of our hemodynamic resuscitation. If it's less than 10%, then it's associated with increased mortality.
Thank you so much for that answer, as well as for the presentation. Guys, one final chance to ask Dr. Fitzwanga a question. Anyone? Okay, so you can send, I'm sure, your questions through later if you have any, and perhaps plan another session with her at during your 12:30 tutorials. Not so, Dr. Fitzwanga?
Yes. I just saw a question in the chat about how to calculate adrenaline and noradrenaline. So that is different institutions have different protocols for dilution. So it's good to use the protocol, because The commonness, a lot of pediatric ICUs use micrograms per kilogram per minute. And we start with 0.003 micrograms per kg per minute up to a maximum of 2 mics per kg per minute for adrenaline and noradrenaline. But it's always good to refer to your institution protocols in terms of what units they use and their dilution charts, so that then you're more aware. This is something that we need to also be very, take when the nurses are doing the mixing. It's important to know, because you see, they make sure that they label the syringe so that you know what is 1 ml per hour is equals to what. If your institution is using mics per kg per minute or mic per minute, it depends on the institution, but most pediatric ICUs use mics per kg per minute. So it's very important to insist that the nurses label, so that if anyone who's not on shift comes and they see 1 ml per hour is equals to